Well, welcome everybody. Thank you for waking up so early and joining us for this fellowship lecture in lymphedema. I think you find some of this stuff perhaps a little bit of a review after the wonderful lecture that Dr. Stewart presented last week on edema, because they're very much interrelated in how they translate to one with each other. So I'm going to give you pretty much a crash course on lymphedema. This is part of what your specialty now is. It's the American Venous Lymphatic Medicines Society. Okay, it's not just venous, but now lymphatic because of that interrelationship. So let's talk about lymphedema. Pretty straightforward. I think you all should be very well familiar with the definition of a chronic and progressive accumulation of protein-rich fluid in the interstitial spaces, which are referred to as lymph fluid. Okay, and it's that leads to tissue changes and impaired immune function. Okay, and it's really secondary to this function of the lymphatic system. What is this lymphatic system that we're so familiar with now? Well, it's a interconnection of a vascular system. And I always say I love this picture because when you look up the anatomy of the lymphatic system, what you're going to see is the same picture but never with the representation, the pictorial representation of the other vascular side, the veins and the arteries. And I think we need to be conscientious that they are very much all connected. And as we do more research and we verse ourselves better with regards to lymphedema, we find out more of that interrelationship, again, especially with regards to the venous system. So the lymphatic system facilitates fluid movement from tissues back into blood circulation. Obviously, it's how proteins return back into the cardiovascular system from that interstitial fluid. It's in charge of removing waste. At the same time, it's actually works as a immune system surveillance for both bacteria, viruses, and cancer cells. So it's a very active system overall. It's not just moving water molecules. And the anatomy and physiology of this lymphatic system is very similar. If you were a vision, this should be really a review that the system is no different than our vasculature of the arteries and veins, right? It's composed of capillaries, vessels, and trunks. It has lymph nodes, which are filtering stations, and then major ducts that help mobilize that fluid back into the primary circulation by the subclavian veins, okay? Now, the movement of this fluid, again, not different than what we already are familiar with from the venous side. Okay, it works through a series of valves, and at the capillary level is very simple. These are kind of one cell thick capillaries that connected with surrounding tissue in these anchoring filaments. And as fluid pressure increases, it activates these filaments to open up these channels. And the stimulation of the anchoring filaments allows the fluid then to enter the capillary via this specialized junctions. And as the junctions close, they propel that fluid back up. And here we see a nice microscopy view with staining of how those valves look. And you can see that they really know nature is wonderful and not reinventing the wheel and using the same valve, very similar valvular system as we see in the veins to help propel this lymph fluid upwards. But capillary system, as any single cell system, is very fragile, and it responds to excessive stimuli. And any sort of inflammatory process can lead to transient or permanent damage of those vessels. So when we have increased inflammatory process and increased swelling, obviously we start seeing some of the recruitment of additional immune cells, such as macrophages, which start producing further cytokines, which lead to excess fibrinogen production, leading to the increased epidermal thickening and other skin changes that we so are familiar with in lymphedema. And when we improve the overall milieu of that region, obviously those lymphatics can then recover and help with improved function and recovery of the entire system. But as Dr. Stewart alluded earlier, he stole this. That's what I'm going to say. He stole it. He took it. I had it first. Now, he did a great job at introducing the EGL layer. Okay, and you're all very familiar now with what the EGL layer does, and it's just this very gel-like matrix with hair-like protrusions within the lumen of the cells, and these are the true regulators of fluid movement in and out of the vasculature. And where we thought that there was a movement of fluid in and out of these capillaries, and what the Starling principle alluded to, we now, because of this EGL layer, we know that that's no longer really holds true. And really, fluid moves out of the cells and very little out of the capillaries, and very little moves back into the capillaries through the vascular system. The majority is really moved through the lymphatic system. So it's really a more of a constant outflow and uptake by the lymphatic system. Now, it is this EGL layer that is very sensitive to any sort of tissue stimuli, such as inflammation, ischemia, sepsis, trauma, diabetes, excess IV fluids, and it can shed itself. And then you end up with this further outflow of fluids. This is something similar that we can see in chronic venous insufficiency. So as I mentioned earlier, the initial Starling principle and how we thought that microvascular fluid exchange happened has really now been revised. We felt that 90% of the fluid was returned back into vasculature and about 10% into the lymphatic system. And this is no longer true. So when we take into consideration the EGL layer, what we're really seeing is a new revised Starling principle in which the majority of the fluid, pretty much 100%, is returned through the lymphatic system. So when Dr. Stewart was talking about edema, he very much alluded that this is now a spectrum of any sort of edema, a spectrum of lymphedema, and it's really a continuum of the disease. And that's how we have to think about lymphedema. There is edema, which we can consider as a transient incapacitation of the lymphatic system, and it's usually a low protein and pitting edema, versus a lymphedema, which may represent a permanent damage of the lymphatic system, or a protein-rich and the traditional non-pitting fluid. But they're all the spectrum of that lymphatic injury. And when we look at lymphatic failures, we can classify them in three different fashions. Okay, we can have a dynamic insufficiency, which is an increased lymphatic load on a healthy system, so too much fluid for the current lymphatic system, such as congestive heart failure. Mechanical insufficiency, which is a normal amount of fluid, but an impaired transport capacity. This is classical of primary lymphedema, so congenital conditions in which people are born with faulty lymphatic system, or post-surgical conditions, as we often see with oncologic patients. And finally, a combined insufficiency, which is an increased load and a damaged lymphatic system, which we so commonly see with fleval lymphedema from chronic venous insufficiency. We further can classify lymphedema as primary or secondary. As I earlier mentioned, primary lymphedema is a hereditary malfunction of the lymphatic system, okay? And it can present at different stages in life. It's not obviously, it's a very straightforward diagnosis. If you see a child, an infant with a swollen limb with no injury, as Dr. Stewart alluded during our last lecture, if you see a young person with swelling, well, it's usually one thing. But when we see adults, it's usually a multitude of systems leading to this swelling. But in congenital primary lymphedema, if we see a child, really, if there's no trauma or any other obvious injury, we have to think that lymphedema is the cause. And now, if it presents later in life as lymphedema tarda, obviously the diagnosis can become a little bit more complex. Secondary lymphedema, not going to rehash this, but obviously it's secondary to additional conditions such as post-cancerous surgery, chronic venous insufficiency, traumas, obesity, active malignancy, medications, etc. What is the epidemiology of lymphedema? What is the true incidence? Well, there are a lot of approximations. As you read the literature, somewhere between 140 to 250 million people worldwide. When we look at a primary lymphedema, it affects about 1 in 100,000 individuals, so not, thankfully, as common. Secondary lymphedema, this is a lot more common, a 1 in 1,000 individuals, okay? Biliaris is still the most common form of secondary lymphedema worldwide. And in the developed world, when you look at the data, the multiple reviews, they continue to put the majority of lymphedema due to malignancy treatments. More and more, you're starting to see the mention of chronic venous insufficiency, but malignancy treatments, oncological procedures have always been the lead presentation in the Western developed world. But is that really true? I have a hard time believing that when chronic venous insufficiency is the most common vascular disorder worldwide, one of the most common manifestations of chronic venous insufficiency is edema. And we know that edema equals a transient incapacitation of the lymphatic system. Well, what is really the true incidence of lymphedema? Probably a lot higher. And what is really the primary cause of secondary lymphedema is probably not oncological procedures. It's probably more chronic venous insufficiency as a result, or at least just as much as oncological procedures. But we don't have any good data about that. How do we diagnose lymphedema? Well, we can start with our MRIs, CAT scans. Often we see them in our duplex ultrasounds that we see that it reveals those large lymph nodes. We can find obstructions, oncologic masses, unfortunately, which can be adding to the outflow obstruction through the lymphatic channels. There are bioimpedance spectroscopy. This is a non-invasive and a low-cost way of assessing lymphedema within a limb. It is available at certain sites to be performed and confirmatory of lymphedema in the site. But the true and tried gold standard has been radionuclide imaging of your lymphatic system, also known as lymphotentography. So this is just injecting a dye in the area that distal that you want to examine, and then see what the uptake of that dye through the lymphatic system is. Obviously, it's, as you can see through the images, probably not very pleasant. And from what I hear, it's definitely painful. It is time consuming, and there is radiation involved. So specialized testing centers are needed. You should be aware that there's also near infrared fluorescent lymphatic imaging. Right now, it's mainly used in research, much like lymphoscintigraphy. You inject now a indocyanide green dye into the interstitial space, and you see how that dye gets uptaken by the lymphatic system, and you visualize it using really night vision. And sort of just can see here some depictions on how the system works and how you can identify faulty lymphatic systems. But again, mainly in research, don't know of anybody in the area, at least locally here, on the immediate state vicinity that is doing this. I am going to present to you the staging of lymphedema, the International Society of Lymphology staging system. I think this is the most common. There are others out there, but this is the most often used and quoted one, in which you go from stage 0 to stage 3. Some sites I've seen them label stage 0 as 1 and go through stage 4, but it's exactly the same thing. So stage 0 is a subclinical, so no swelling, no skin changes, and may never progress. This is your classic oncological patient that just had their lymph nodes resected. We know that there is a lymphatic injury, but there is no manifestation of that lymphatic injury. These are the patients that you want plenty of education on and let them know what to look for so they can address any changes immedially. Stage 1 is very responsive to elevation. There is some pitting edema. There's usually no skin changes apparent, and it responds really well to treatment. This is where you really want to capture any patient at all times, because you can, with a lot of education and development of good habits, you can make a real difference long term. Stage 2, at this point, the swelling may not reduce. You start seeing some tissue firmness. Okay, skin starts to get a little bit hardened, and it can still very much improve with treatment, but it gets a little bit harder to do. We do tend to see a lot of these patients in our clinics. Stage 3, no elasticity to the skin. The skin is hard. It has a increment folds. I'll show you some images of that. There can be open wounds associated with them. They are propensous to infections more frequently, especially fungal infections. And these patients do require a lot more intense therapy, but they still respond to therapy. And you start to see some of the classic signs of advanced lymphedema. The Stemmer sign, okay, is pathognomonic. You should be familiar with it. You should really be performing in all your patients. Very nice and easy to do. But observe they're swollen and square toes. That skin appearance starts becoming like an orange peel and starts developing some hyperkeratosis and some papillomatosis. These patients can have some lymphorrhea present. You have that buffalo hump on the dorsum of the foot, which is also pretty pathognomonic of the condition. How do we treat lymphedema? Well, first, let's start with pharmacological therapies. There really are no approved pharmacological therapies still in the market, but there are some things that have shown helpful. First of all, are the flavonoids. There are some small studies which studied the micropurified form of the osmin, and these patients, again, though small study, did show some improvement in their overall swelling. And when they did lymphocytic parameters, there was some noted increased improvement in how the osmin patients versus placebos had mobilized through the lymphatic system. So I like it because it's not harmful to the patient, really no side effects. It does not interact, and if it does provide some additional benefit to that patient, I think it's great. I think that most recently we had, Dr. Nguyen had mentioned lymph formula and how it has contained selenium. I looked that up, and data has shown that patients with lymphedema show continuously depleted levels of selenium. And selenium is key in as an antioxidant in help healing tissues. So that's why selenium is added to some of this formula. So I find that very interesting. Ketoprofen is an NSAID, and it's a COX inhibitor. and it was Dr. Stanley Roxon identified that patients that were treated with ketoprofen had some improvement in the overall histopathology and skin thickness compared to those at baseline. The problem with ketoprofen, just like any other NSAID, can be nephrotoxic. Long-term use with gastric complications can be an issue. But through the study of ketoprofen, we found that it's not just a COX inhibitor, but it's also and what it called a LTB4 inhibitor. So letopagine, can't pronounce, I apologize, inhibitor. So that led to the some new study that is currently is supposedly to be published anytime on ubinimex or bestatin. Bestatin is a pharmacological agent that targets LTB4 and induces lymphatic repair. It's been used in Japan as a cancer treatment. It has not been shown to have any side effects. So this is possibly, we'll see what it shows. It might be helpful. There's also now in study lymphedema, which is an investigational adenoviral-based gene therapy. It leads to the expression of growth factor. VEGF-C is the main growth factor, and it's sort of been shown to have some lymphogenesis. Now, with the recent COVID pandemic and the mRNA technology, so instead of using this adenoviral vectors, they are looking at mRNA. So this is a continuously evolving field. I would like to remind everybody that diuretics in the reduction of venous and intracapillary pressure do not work, okay? Think about the EGL layer. So when you take that into consideration, the sequence does not occur in lymphedema, hence the fluid cannot be mobilized into the vasculature space. So these patients are not really are going to benefit in true lymphedema from the diuretics. Briefly over surgical techniques, there are really three main ones: lymphatic bypass, lymphatic venous bypass, and vascularized lymph node transfer. What I want you to know about these is that they are highly selective patients. Okay, so surgical candidates need to have localized primary lesion. They have failed non-operative management. They have recurrent complications. They obviously have to show limitations of their ADLs and general function, chronic pain, overall diminished quality of life. So those are the candidates. The contraindications: excessive tissue fibrosis, late stage lymphedema changes, venous hypertension, recurrent cancer, obviously in patient non-compliance. These procedures are coming a long way. Just a few years ago, the success rate was below, in double teens. Now we're looking at some success rates above 50%, 60, 70% in some by some surgeons. So this is also very much of an evolving field, and some patients might be candidates for this. So just be familiar if there's somebody in your area locally who might be performing these procedures, get to know them, learn from them, learn who are the best candidates. So perhaps we can improve the quality of life of these patients. Okay? However, complete decongestive therapy continues to be the gold standard, and it is a multimodal approach to the management of lymphedema. Okay, it's composed of manual lymphatic drainage, compression bandaging, exercises, meticulous skin and nail care, as well as patient education, with the overall goal, obviously, to reduce the volume, restore mobility function, reduce the risk of infections, and overall quality of life improvement for the patients. So 2 phases to CDT. Phase 1, which is in clinic, Goals are really to decongest, reduce the volume as fast as possible through some of the methods that we already mentioned. Takes usually about 2 to 6 weeks, every patient, depending on the how advanced their disease is and how the amount of volume that they're carrying. That determines the duration of their treatment. Usually multiple visits within a week for the patients, again, depending on the level of disease. And this all translates then into phase 2, which is the long-term self-management, which is to maintain that reduction, minimize a progression again, and continue to reduce the risk of infections and other complications. And this is achieved through compression garments at home, bandaging that patients can do, self-MLD, pneumatic compression devices, exercise, and skin nail care. And you can see here the results of CDT, very impressive, even where you would think that there is really little hope. With the proper techniques, you can really achieve some miracles in terms of recovery for these patients, and you can truly tell that these are life-changing therapies for these patients. In terms of pneumatic compression devices, I think you're all familiar with this, but I do want to take note of that these are not a replacement for CDT. These are really to work in conjunction with the CDT process. So patients benefit tremendously from them, but you need to make sure that you explain to your patients that this is not to replace their bandaging, their exercising, their self-MLD. These are adjunctive therapeutic devices. Why is lymphedema? Obviously, outside of the deformity and burden in the quality of life, it has the risk of infection, both bacterial and fungal. We all have seen those patients that unfortunately that infection will progress rapidly into a more systemic infections and require hospitalizations. So these are not just minor infections. They do develop lymphorrhea and they develop wounds that tend to not heal. They have obviously chronic pain associated with this, as well as discomfort. They have limited activity, psychosocial. I don't think I need to, after seeing those past pictures, you can only imagine the level of anxiety, isolation, as well as the stress associated with financial care of this and the effect it might have on relationships of these patients. And finally, perhaps the worst of them all, which is lymphangiosarcoma or Stewart-Travis syndrome, and you really don't want to miss this. Thankfully, it is rare, occurs in less than 1% of patients with lymphedema, and it's usually in long-standing lymphedema. So those patients with chronic swelling unmanaged for 5+ years. But examine these patients carefully, all your patients with lymphedema. If they have any darkened nodules, purple nodules, make sure that you get those patients evaluated immediately for biopsy, because unfortunately the prognosis here is very poor. Survival rate is less than 5% in 5 years, and this is preventable. So we can avoid this by proper identification of patients with lymphedema and making sure that they receive the care that they deserve. So in making sure that our patients are well cared for, then we need to understand that lymphedema is really a disease that really takes the help of multiple specialties, and it takes into consideration, it needs the help of everybody within that patient's nucleus, family nucleus. So the physician is involved, us, the phlebotomist is involved, the lymphedema therapy is the podiatrist, the wound care nurse, if they have any wounds, the fitness trainers, nutritionists, garments fitters, vendors. Lymphedema support networks are key here. Social service, psychologists, spouse, family members, they all really need to be involved for this patient to be successful. So when you have this many people needed to be successful in the overall care and success of a patient's illness management, there are a lot of areas in where the wheels can come off and unfortunately fail. And that's where I think us need to be a little bit more involved with these patients. I bring my patients with lymphedema back regularly, just really to chat with them. And I let them know ahead of time that not to expect anything huge from my visit, but really just to see what, how are they doing? Are they still within compliant with the therapy? Are they getting worse? Have they had any issues with getting their garments, their pumps? Do they need new garments and pumps? So it's really just to keep them engaged, assess if they have any problems at home in doing the therapy, why, in getting their primary care doctor involved or other family members involved. So it's just really a conversation to keep the engagement on the therapy, because this is a long-term treatment for them, okay? So again, just quick recap, all edema is a form of lymphatic dysfunction, and whether it's transient versus permanent. Try to identify the etiology of all your patients. So always try to find out why they have lymphedema. The most common form of lymphedema might be febrile lymphedema. Manage expectations up front, okay? About all treatments and what is this going to look like long-term for them. Treat all edemas, okay? Avoid the diuretics, educate providers that are prescribing this. And again, don't forget that multidisciplinary approach. And when we used to say, hey, this is what lymphedema is, and we used to think about this cartoon, it's just kind of like, you know, a little bit funny. We will now realize that really this is lymphedema, and it's a spectrum of disease, and it's not just when your leg is deformed and elephantatic that you have lymphedema, but early on, and we need to make sure we identify these patients and treat them appropriately, okay? These are some resources. You can always share this slide with you later, don't need to. And that's all I got. Good, just about over 30 minutes. So I'll open it for any questions.
Hey, that was excellent as always. And you know, every time I hear your talk, I think I learned something new. Just a couple of things for the fellows. I took a couple of notes. You will almost assuredly see a question about ISL staging. So make sure you know the staging pretty well. Your slide about the incidences of primary and secondary lymphedema, that's definitely going to be on the test. And then questions about lymphangiosarcoma, Stewart-Treves syndrome. I think I've seen that on the test as well. With regards to lymphedema formula, I know you guys have seen an email from me yesterday. I'm very confident that we are going to strike a deal, and they're going to come to an understanding that, look, we just have to protect ourselves. You know, as physicians and providers, we're recommending the drug, and because we are profiting from it, because of the fact that PBR is paying our physicians a percentage of that, it puts us at risk if there's ever a contamination event, some type of fungus that grows in there. Who knows, right? They could have an unhappy staff member who laces the product with cyanide. We just have to protect ourselves. And so we strength in numbers. Okay, the fact that we have stopped all orders yesterday, they've already come back to me and said, hey, how can we work this out? So I'm confident we will have some type of NPFF available for you, whether it's with vein formula or with somebody else. We will have a product, so that way you guys can order. And you know, that's just last bit of advice from me. Manage lymphedema early. Okay, you don't really want to get to the stages of stage 3 where the leg is just overflowing with swelling, and they can't even get the garments on. They can't even get comfortable. You really want to get on top of this early, because it winds up being so much easier, and it winds up saving money. It actually saves the insurance companies money if you actually get to it before it gets to stages 2, 3, and beyond. Okay. So open up for any additional questions, but great talk, Eddie.
I I have just a comment slash question. How do you, Eddie, how do you approach the discussion of diuretics? If the diuretics are not being used for any other reason, like blood pressure related, and primarily only for swelling, I'm always like a little hesitant to walk that line. I know it's beneficial for our lymphedema patients, and it's actually harmful in the long run to have them on, a diuretic. But at the same token, there's two parts to that, where the patient will not have that honeymoon period where the swelling does go down a little bit, and also the primary care doctor and our relationship with them can also kind of sometimes be very touchy. So because now their primary care is the one that's told them to be on it, and they've been on it for a while, and as a referral based practice, there's always that little line that you have to walk. So I was just curious how you, if you've had to approach that, how you approached it, or do you not approach it? What do you do?
No, thank you. That's a great point. It is a very touchy thing because, as you said, a lot of them they're not on diuretics from us. They're on the diuretics from their referring provider, the primary care doctor, and you don't want to sort of step on their toes. You do not want to tell them it's wrong. But I think it's all about communication and education. And so what I do, number one, I let the patient know that, hey, how much improvement have you seen from your diuretic? And they say, oh, just a tiny bit, and now hasn't improved any further, and that's why I'm here. Mm-hmm. And they're there because their primary care doctor sent them to you because they're not improving further. So it's actually an easy, nice transition of saying, okay, you got that slight improvement because you're not filtrating as much fluid. There is a decrease in vascular volume. That's why you're seeing that reduction. So the lymphatic system sort of catches up because you don't have so much filtration. So what we're going to do is we're going to put you on treat whether it is venous insufficiency or it's just lymphedema. We're going to treat that swelling, and then we're going to try to transition you out of this diuretics. And I talked to their primary care doctor about this, and I let them know, and they usually are very happy. They understand. I talked to them about EGL and how we see lymphedema now, and they're super thrilled to learn about this. And as long as they know that their patient is being cared for and that their swelling is improving, they don't care. I mean, they give them the diuretic in the first place because they have 10 minutes to see them, treat them, and get them out the door. And their patient is expecting some therapy from them and some benefit. And the diuretic clearly creates that honeymoon period, as you called it, in which patients are satisfied. They are seeing some improvement, but they don't know better. It's sort of a managing expectations, communication, managing what is healthcare now, and we can do it better. That's all.
Great, thanks.
Any other questions, guys?
Feel free to reach out if either afterwards or you feel comfortable with the form, whatever. Just always call or email. Dr. Nguyen, sorry.
Well, thanks everybody. Have a good Friday and a good rest of the week. We'll see you guys next week. Take care.